Good morning. It's a pleasure to be here. It's 10 minutes, so no pleasantries. Back in 2010, the Lancet Commission on the Future of Training of Healthcare Professionals for the 21st Century gave a very detailed description of the state of play, training of healthcare professionals around the world in 2010. And it was damning. It was a crisis. It was fragmented, according to the Commission, and it was outdated. It was producing consistently graduates who are ill-equipped to meet the needs of patients and populations. That meant there had to be a response, and every country around the world in groups in various ways produced a response. The Irish Forum of Postgraduate Training Bodies, medical training bodies, produced its strategy document a number of years ago, which describes a plan to address the challenges that had been laid out. Within my own discipline in anesthesiology, we've produced two documents, two consensus articles, the first of which in 2020 describes how a future training program that is competency-based should operate, the mechanics of that. And then the second concentrates on the value and utility of training program outcomes. So those are sort of the roadmap for anesthesiology. And even though they focus on anesthesiology, many of the recommendations have wider implications for other healthcare professions. And since they've been published, many training bodies across Europe, the Royal College of Physicians and Surgeons in Canada, the Harvard hospitals, and many others have endorsed this direction. I'm not going to try to either describe the problems that are being confronted in training or in great detail the solutions that are being presented, but this is a core message from both of those documents. This is what's going to be necessary. The training of healthcare professionals in the future will require a systems-based approach. And that can be either a very vague term or a very specific term, depending on how familiar we are with system science. And to operate that will require some kind of logic model. Here, in very simple terms, at least for me, is how it works at each level. So one could consider this from the level of the trainee, the trainer, the director of the training program, the medical regulator, the education funder, the policy writer, Minister of Health. Consider it from any of those. We'll have different perspectives within the audience. The relevant data must be recognized, must be accessed appropriately, and it must be used. I'll come back to that word in a moment. Used in a good way, such that it is presented in a timely and comprehensible fashion to a person or person who's both able and responsible for responding to it. And that response itself must be measurable. The response will normally be an activity or a change in activity. That must be measurable, and that becomes a critical data stream for the original data set that I mentioned. And that needs to happen both across each of those levels and within those levels. Maybe a little bit more specific. What I said seems like no more than common sense, but it doesn't work. It doesn't work in our system, and it doesn't work in general, except for a few isolated exceptions where a huge effort has been made locally. We have three enablers that require reinforcement. One of the enablers is the relatively new science of learning analytics. And what that can do is take the data and do the four operations. It can summarize it for us. It can extract meaning or interpret or analyze it. Occasionally, it can predict the future, and it can present the visualizations that make it comprehensible to the appropriate person. That's what learning analytics does with that sort of data set if it's provided appropriately. But the decision is made by a person or persons. That's absolutely necessary. The nature of our system is so complex and so poorly predictable that all the elements of wisdom and expertise and dealing with ambiguity Finally, a decision needs to be made, and it requires a human in the system. And that person must demonstrate those characteristics. We need to up our game in terms of reflective practice. And I don't mean just reflective clinical practice. And finally, the result needs to be measurable. And that means, in real terms, and I'm talking about training now, the performance of individuals and teams needs to be measurable in a way that is valid and reliable, and ideally referenced against a proficiency standard. That's the big picture. An example. Over the last 2 or 3 years in Cork, we've been employing augmented reality in some of the teaching of undergraduates, medical students. We do it in 3 sort of ways. One is in clinical encounters, sort of bedside teaching, the supervision of new procedures like IV cannulation or peripheral nerve blockade, and also co-designing, co-creating holograms, artifacts. So augmented reality, I think you'll be familiar with it. It's no more than the placing together in a single setting real and imaginary objects and allowing those to be perceived by people, usually more than one person. It's Dr. Murray Connolly who's leading this for us in Cork University Hospital. And that's Murray speaking with a patient, doing a preoperative assessment, and sharing the experience interactively with a group of medical students who are remotely placed in a lecture theatre. You could probably achieve most of that with a GoPro and no mixed or augmented reality. So where exactly does the advantage lie? And you'll see certain advantages appear to be the fact that you can undertake a new procedure with an expert on your shoulder, participating in the procedure, so-called remote proctoring. Or you can enable students on their own devices, separately or together, to participate in a clinical encounter, bedside teaching. But the real value, it seems to us, and we haven't measured this yet, is in horizontal and vertical integration. In other words, the purpose of the bedside teaching is not to impart knowledge, or it's not to do a demonstration of how it should be done. It's to collaboratively build a model that is shared and comprehensible, so that, for instance, if I'm assessing a patient who's experiencing pain after surgery, which is one of our standard cases, that I can go to the patient, interact with the patient, the student can remotely interact with the patient, and I can go from there down to the genome and back up to the patient's voice without having to depend on my certainty that each student can recollect the bits of science that I'm proposing they do. And for that purpose, I use holograms or artifacts. Here are some of the artifacts that we use for that purpose, for instance. And these can be juxtaposed or superimposed on the patient during the assessment. I'm not going to try to explain this because I've forgotten some of the receptors. So an example, back to my original diagram, by that clinical encounter, I've created a data set. That data set is co-designed, co-created, and stored in such a way that a person, perhaps the learner, perhaps the trainer, perhaps the program director, has access to that, such that something has improved as a result. Might be the likelihood that I will answer a question correctly in my next exam, or that I'll undertake a history for a similar patient well or better than I would have otherwise done so. And that activity itself can be created. It creates a new data set. I'd like to finish by thanking, even though that's a relatively small piece of work that I've presented here, many people, my colleagues, have contributed to a far greater extent than I have to the work on mixed and augmented reality. So I'd like to acknowledge and thank them, as well as the different funding agencies that participated. So thank you for your attention.